Care of the sick, elderly and vulnerable is a major challenge for society and is an area where the 12 charities that we support through the Stort Valley Rotary Charity Helping Hearts, and they've developed an incredible expertise in this area among young children. Professor Trivedi tonight will be talking about community engagement and health inequalities and providing cancer support in the community at a challenging time. So Daksha, I will hand over to you.
Thank you very much, Gordon, and thank you very much, everyone, for inviting me to this session. I'm really delighted to be here. So I just wanted to say that I will talk about some of my work around health inequalities and also my own cancer support work through my own cancer journey. I'm also part of the NIHR Applied Research Collaboration. So that's a government's initiative to conduct research and development and implementation that meets the needs of local populations. So the ARC, so it's called, NIHR is National Institute for Health Research, which is the government, the Department of Health. And the applied research collaborations bring together health and social care professionals, researchers, charities, and the communities we serve to come together to develop to develop research that meets the local needs and then go into implementation and service development. So I'm also a co-chair of the Hertfordshire Public Health Connect Strategy Group, which is a formal partnership between the University of Hertfordshire and the Hertfordshire County Council. And again, with that forum, we network with Hertfordshire Health Watch and other community networks. So I'm leading a sub-theme within the Centre for Research in Public Health and Community Care on the health disparities around marginalized, disadvantaged, ethnically diverse communities. And I'm leading the mental health side from University of Hertfordshire. And I lead a number of East of England projects on prevention and early detection. So, sorry. Slide. So this is just to show how my professional life and my voluntary work becomes congruent. So I'm a patient advocate for prevention and early detection of cancer, and I volunteer across NHS Forum, Cancer Alliance East of England, both professionally and as a voluntary, and particularly also around ethnically diverse initiatives, both at the local, regional, and national. I run community support groups, and I'm also a Macmillan Buddy volunteer for patients and their families, which means I talk to cancer patients and their families a couple of times a week. I collaborated with both professionally and in my voluntary aspects with Cancer Alliance services, again, to promote knowledge and awareness in diverse communities. And I will discuss some of the challenges around that. I collaborate with the South Asian Heritage Foundation in Hertfordshire, based in Watford. I'm on the advisory board, and it's one vision which brings people together. Okay. So just to give you an outline, I'll just outline health inequalities in the policy and the research context and how is that related to ethnicity. I will then talk about the community engagement work I do using the principles of co-production. So we moved away from researching to the community and researching with the community. So more about that. I'll share some examples of both my professional and voluntary work, which actually highlights the value of reaching underserved communities, and then my cancer support initiatives and how they link with what needs doing in the community, and then discussion. My slides are going very fast. Okay, I just want to start with my personal journey. So my twin brother died of an aggressive esophageal cancer in 10 months since diagnosis. He was given 10 months to live, and it was inoperable because it was very aggressive. And then shockingly, 6 months after we said goodbye to my twin brother, I was diagnosed with exactly the same cancer, which was an aggressive esophageal cancer. And my prognosis was deemed poor at the time of diagnosis. Lots of uncertainty for 3 months, a very challenging time because my elderly mother, who's still with us, was 87 then, and she'd already lost both boys. His twin brother through the cancer and an elder brother in Welwyn Garden City who died of a sudden cardiac arrest. So here I am, shockingly diagnosed 5 years ago. I wasn't given 5 years, I can tell you at that time. My prognosis were instead, but I was told that I had a very aggressive cancer and it had already started to travel and gone to my stomach, the junction of where my esophagus and stomach is. So the question that went to me was, who do I talk to about how I am feeling and what I need and where do I go? Because this is not what's given to me, or was not given to me at diagnosis. It was 3 days before New Year. And I was just told that a locum had to be brought in to give me this bad news. And then we had to pretend a new year with an elderly mother because I didn't have the heart to talk to her because she's already got heart failure. She's had heart failure for many years and just getting over really 6 months before, just coming to terms with everything that had happened, the bereavement and everything. So again, that's what is it that we need? What culture do we come from? Who can we talk to? Can we meet the needs of people holistically in some ways when they are given this diagnosis? So soon after, during my recovery, so I mean, cut a long story short, I had a 9 hours invasive surgery. I don't have an esophagus and my stomach is here now. And they cut my stomach. They removed my esophagus after a 9-hour harrowing surgery with a high risk of mortality and a high risk of pneumonia, which I did get pneumonia and I'm here. And so it's a harrowing thing for someone to go through. And it took me 11 months recovery with a lot of help from my family, my husband and my elderly mother, who was determined to make sure that I had some good quality of life and outcomes from her only surviving child. So during that time, the BMJ invited, the British Medical Journal invited me to write a piece. And they said to me, can you tell us about what your patient is thinking? And I said, well, actually, I am a patient. And so I discussed with them how a family history of cancer, I was affected during my diagnosis, how the health professionals could better support patients from different cultural backgrounds. I mean, you might be thinking, what is it so different about my having this cancer, this horrible kind of, I think with esophageal cancer, I have to say there are no screening programs. There's nothing. Survival is really poor. I was told all that. There's literally nothing. And again, the intervention itself comes with a very high risk of poor outcomes. So something that I did discuss with in this article in What Your Patient is Thinking is how could professionals perhaps think about the variation in understanding and information needs of certain families from different backgrounds? Are there ways that they could address those concerns? How could you better ensure that family people are included? I had an elderly mother who sat outside the room. I must admit, when the Macmillan nurse went in, my heart just stopped. And I just asked them, I said, what do I tell my elderly mother who's sitting outside, has lost both boys? And that was it. I was just told, actually, that I've been brought in to give you the bad news. And I'm really sorry, but somebody will be in touch with me. So there's this issue around communicating the diagnosis, not just with South Asian families, with everybody. And there's a lot of literature on how you communicate a diagnosis can affect your whole cancer pathway. And also the family history of having a cancer does increase the worry and the stress, like I did, just taking my twin brother through end-of-life care. And also, how do you communicate facts around the diagnosis that could provide families something positive to focus on? So just to say, so the health inequalities, we know there's the Public Health England strategy about community engagement, improving health and well-being and reducing health inequalities, very much in the NICE guidelines. And there is a Hertfordshire Health and Wellbeing Strategy, which actually reports and highlights the ethnic health inequalities. And that's not just for ethnically diverse communities, but for marginalized, disadvantaged groups. And I'll give examples of that. So just while we're talking about this subject, it's good to recap on what we mean by health inequalities and We know from Public Health England that there are avoidable and unfair differences in health status between groups of people. We all know the examples are our outcomes, our quality of life, access to care. But there is a point there which says quality and experience of care. And that quality of care is different from quality of life. And that's where, patients, families, carers, communities can tell us what that experience of care is. And again, inequalities between whom, socioeconomic factors, there's gender, ethnicity, and there are other socially excluded groups. I also lead the mental health work for mental health and neurodiversity in the East of England. I co-lead it with a colleague at the university. And again, that is a group that is got very fragmented care. So it's really a group of people who are not able to access the care they need. So this is just to highlight that we have been talking about health inequalities and we're making some strides, but we're still talking about it because there is still a huge kind of unmet needs with a variety of communities, range of communities, learning disabilities, neurodiversity, travelers, LGBTQ communities, and ethnically diverse communities. And I just wanted to sort of say that this slide actually shows it's everybody's business. If you look at the little picture on the top right-hand corner, it says equality versus equity. So I think when equality and equity, they both strive to achieve better outcomes and access to healthcare. They're not exactly the same, because equality refers to equal access to everybody, because these are unfair differences which are avoidable. And then equity aims to adjust the resources for disadvantaged groups, so you're meeting specific needs. So when we address equity, we will be able to address these health inequalities that everybody talks about. And again, I've mentioned some of the groups, but again, the reasons, you might be thinking, what are the reasons for all this? Well, it's a complex picture, complex for different communities. How services are available, when are they available, language, literacy, poor experience, misinformation, fears, for example, about cancer journey. Where am I going? What's going to happen to me? Oh no, or the other way to say, I don't have any symptoms. I don't need to go to the screening program. So the government's latest strategy is the Core 20+5, which is an approach that is designed to support the care that is targeting action in health inequalities. This is just to give you the picture of where we're at, what is being done about that. I just wanted to show you something about, just so that while we're talking about community engagement, health inequalities, and with the South Asian experience, this is just compared to the 2011 census, this is just shows the 2021 census, just showing that there's an increase in ethnic group distribution from 2011 to 2021. And that really just shows that different categories of ethnicity, different groups, there's been an increase. For example, the Asian British or Asian community has gone up from 7.5 to 9.3%, and similar with several ethnic groups. And that's just to give you the national context. If you look at Hertfordshire, again, it reflects the national context, but again, you can see on the left-hand side, the pie chart, it just gives the percentage of ethnically diverse communities in Hertfordshire. And on the right-hand side, it just goes by the different districts. And again, you can see that, Watford is 24.5%. But totally, if you look at East of England, overall, it's a 6.4% and of Asian groups. And that's reflected with other groups. Again, there are pockets, and I don't have a 0% or even 1% in any of these districts categories. So we are actually looking at Hertfordshire being a part of a diverse community. Examples of health inequalities, certainly from our own work in the mental health. This is just from an older survey, 2016, which actually just shows that the likelihood of receiving mental health treatment is low in several ethnic groups. So the bottom bar chart is for the white British, and the bar charts along that is for the different ethnic groups. And this is from the Adult Psychiatric Morbidity Survey, so 2016. So I think the current data, which is not been available at the moment, reflects more or less a similar picture. So we are making strides in some areas, but we're not, because we don't know what the local needs really are, and maybe we need to come together with the service providers, with the health professionals, with researchers, with implementers, but with the community themselves to address this. Again, an example of bowel screening uptake by group. I'm actually working on the bowel screening uptake for Muslim women. Public Health England, East of England, gave some data which showed that uptake is approximately 28% lower in people of South Asian ethnicity compared to the general population. And together with the NHS Cancer Alliance and the British Islamic Medical Association, the university is I'm leading that work on looking at developing a tailored intervention that has been co-produced by Muslim health professionals, and we are evaluating that in 2 sites. And if we find that there's a difference, we would like to roll it in the rest of the East of England. So this is just an example. And again, breast cancer and ethnicity, we do know that South Asian women are less likely to, or ethnically diverse women are less likely to attend breast screening compared to white women in the UK. Still, that exists. This is you know, it's like a rolling area which still exists. They present late for diagnosis, resulting in poor survival outcomes. They do have a lower breast cancer awareness and knowledge of symptoms and risk factors than white women. And they do report higher levels of depression, anxiety, and poorer quality of life. This actually data I'm working again with NHS Cancer Alliance, and I just want to talk a bit about the community engagement work around this. So what is a problem? The key message from my own work with the cancer support and my own approach to my research on health disparity clearly says one size does not fit all. There's a load of stigma and unmet needs across different communities. There are cultures, beliefs, and behaviors about access and engagement, the communication, language, and literacy. And I think the COVID has almost widened some of the existing inequalities that we all know about, but that what we have got is a dearth of culturally appropriate interventions throughout the early years. And therefore, there is a need to work on the cultural competency amongst the healthcare practitioners. But we cannot do any of this without consultation with public, patients, and communities. So this is, again, my work is understanding the needs. I've just started some work with Inspirited Minds, looking at who has looked at barriers to seeking mental health support in the Muslim community. I have just leading a program of work which is going to be funded by the government, by the NIHR, on evaluating and on developing and evaluating a tailored intervention for young Muslim women, because the problem of depression, anxiety, and suicide rates have increased among this young population compared to the general. And I think the alarming sort of finding is that they are under-referred for mental health support services. So there is a lack of trained health professionals. And so this remains, and I'm delighted to say that the university is leading on this work with collaborators from, and again, we've got community engagement, which is very strong to direct us to work with us through patient and public involvement to help us take this forward. And also my work on breast cancer and South Asian women. So reaching the hearts of our communities, I did mention community engagement. So this is a collaboration between us and the East of England, and we're looking at how South Asian women engage in breast cancer care. Now, I must say that when people work with either BAME communities or South Asian, do you know what? You're really working with a heterogeneous group of people. And so there will be differences even within those South Asian groups of language and culture and religious beliefs, and so on. So we were fortunate with this work. We're working with an Asian women's cancer group, which has been established for a long time. And our aim was to understand the perspectives of Asian women around breast cancer and care. We wanted to identify the barriers and facilitators to accessing breast cancer care. And most importantly, which is now emerging in the last few years, because we have recognized the need to address the health inequalities, which is still on our agenda, is to co-produce the findings from the project. So it's not university who's saying this is what we're going to do. It is the NHS, the university, and it's the Asian Women Cancer Group who are talking to us and telling us what their experiences have been through different parts of their journeys. So just quickly to say that we had a preliminary consultation with the Asian Women's Cancer Group members who have breast cancer. We used the principles of co-production. We identified the barriers and facilitators to accessing the breast cancer care. And then we actually had a feedback consultation where we went back to the group and said, this is what you told us. What does this mean? And how do we take the next step for providing solutions? And I just wanted to highlight this to say that what this project has highlighted, that the women identified 3 phases: cancer screening, cancer diagnosis, and cancer treatment. So we're looking at prevention as well as treatment. And just to say that it's highlighted the value of culture-specific support groups, which is what I do anyway, and developing holistic needs assessment, which we haven't got, with culturally specific tools to help improve the quality of life. So the kind of problems was information expectations, communication. I experienced a very alarming communication when I was communicated my diagnosis. There's the language and cultural issues. There is the trust, and also involving patients and their families in the decision-making process. And how do you do that? The lack of holistic approach stood out because we know that the NHS has implemented what we call the holistic needs assessment tool for everybody at diagnosis. I can tell you the cancer support groups I'm part of and I run, hardly anyone has ever received a holistic needs assessment tool. So I believe that that's quite fragmented in different localities. So just something that was said as part of this project. It was helpful to take part in the project as it addressed our lived experience, our challenges, and more importantly, we worked together to help identify potential solutions. It really was a listening event in which our views mattered. And then the NHS Cancer Services collaborated on this work, said meeting the needs of South Asian women in cancer care is paramount, and working collaboratively for the first time with a group like Asian Women's Cancer Group. So it wasn't like sending a survey out to just from the NHS, 5,000 women, or getting some data, because survey data does give you the statistics, but how you get people to engage and how you develop solutions together is the challenge. So as you can see, it was the first important step in helping to inform the NHS Cancer Services. So now my personal work, building bridges, I would say I'm taking public health into community service. And I think my support work, I said challenging time. Well, actually, I thought COVID was the most challenging time, but the challenges after that have just escalated, like, the access to the NHS care, access to your GPs, lots of other issues have come to the fore, like the cost of living. But we need to just step back, and when we're conducting compassionate outreach, we need to say, what is a person seeking and what is compassionate care? And I already mentioned holistic needs. What happens to a cancer patient is diagnosis is fine. In my case, I had 3 months of uncertainty, not knowing if I was going to live or die, or how long I had, or the prognosis was looking bad, what they were going to do. So 3 months, and I had no one to give me any continuity of care or support. So there is the thing about treating the person and not just the disease, because if you are given a harrowing diagnosis, it's going to be a long journey or short, but there's going to be a journey for you to go through different phases to receive treatment. and how the person is feeling, what access they've got, what their family is feeling, psychological support, emotional support, in some ethnically diverse communities, even spiritual support, so or any community. And how can we be more enabling, empowering, and building trust? And that's what I'm endeavoring to do in the community support work that I'm doing, is enabling each one of the people in the community to self-management, to manage. And the way forward there is, how do you, I mentioned in my article, what your patient is thinking is about cultural beliefs. For example, I could not talk about it because everybody would assume the worst. Daksha's twin brother has died for the same cancer, so Daksha is going along the same journey. People have notions and beliefs from stories within their own communities. And so it's really important to demystify some of those beliefs. And it put me in a place where everybody presumed the worst. And I didn't, I had to build myself and find myself something positive to focus on. And then engaging to meet, as I said, whole person's unique needs, not our perspective on what should be done. Often clinicians said, well, I think we should do this and I think you should do this. No, I think it's meeting what the needs are, what people want. Like if somebody had asked me, what can we do for you to make your quality of life better? I wish I could have talked to somebody and I would have kind of, because, I'm really thankful to the clinicians who saved my life. Excellent intervention. But the 11 months after that were harrowing, was left alone with very little post-diagnostic and post-intervention care. So that's so again, some of my work with the cancer in the community links with the Garden House Hospice Care, where they've got a compassionate neighbor scheme. And we work with communities who are going through this. And it's very informal support because there is no formal support, or there are no pathways for people when they're receiving treatment or they're going through the cancer journeys. As you know, I run the Mid-Bedfordshire Cancer Support Group, which is quite wide. During COVID, it was national because I conducted it online during COVID. And now we've gone hybrid in our area, and people also log in online. So one key thing that is coming up is they want this kind of support. They want a community support for people going through their journeys. And this is just an example of our group. I'm really proud to say that our group produced a leaflet on just being diagnosed with cancer, what you should be doing, and 30 GP practices and primary care networks are disseminating these leaflets. In every patient consultation, they are giving each patient this because they see that the community support group is a care platform for people who are going through that journey. And we jointly wrote this with the Cancer Patient Services and the Cancer Patient Forum. On the left is our cancer awareness as a workshop with the primary care network of clinicians, nurses, community engagement, communities. And this was the Gurudwara in Bedfordshire, where it's a Sikh community, and we conducted a cancer awareness workshop, which tied up with their health awareness days that they have. It was a Sunday. We went to the Gurudwara and we had hundreds of men and women come up because they weren't even aware how important that screening was actually prevention. That, people just thought either you had cancer or you don't, and then you just get treated or not. But people were not even aware that it was a prevention thing. So a lot of promotion of knowledge and awareness, but in a way that they could interact with us. We went to them, we went to their Gurudwara, we went, we worked together. So that was just to give you an example. This is that. You can see it's not just one person, it's not just me, it's a whole load of people from the primary care network, clinicians, health professionals, nurses, who understand the value of community engagement and community support. And one outcome from this is that I'm going to be meeting with the key people to form a cancer support group that would target this particular community. So these are some of the small steps in enabling transformation. So what you can do, and that's my last slide, just thank you. So you could give to cancer charities. I am going to say that I was so going through a challenging time, that the only way I could deal on my own with me and my husband was to write my journal while I was going through the cancer journey. It developed into a book, and it's reaching lots of people. All the proceeds go to charity. So please share this among your networks. It's my story, but it's got chapters on who cares for carers, what can we do on this pathway, how do we deal with a harrowing diagnosis that we may not have long enough, what can our family members do, what can health professionals learn from this, and how can they come with us together and provide some of the support. So that's my story now, Living the Dream, available at Amazon and on my website. And the other things that we do is help us join action and maybe amplify campaigns. So cancer support groups, the Cancer Voices are telling us, certainly from the Asian Women's Cancer Group, which is a good model to work from, is the value of cancer support groups almost as an intervention or as a step up for all the clinicians to be formally recognized and have a role in getting their communities together and sharing experiences and being part of cancer awareness, promoting knowledge, and addressing the concerns, taking back to the community, to the clinical community, but mainly working together. So, you know, there is a campaign, I would say, you know, have cancer support groups to meet local needs, but that they need to be on a recognized pathway. As you can see, we did a cancer awareness event in one community, and we would like to campaign and do more with different communities. We now, there is an introduction of community connectors. So these are actually community navigators or connectors which work through NHS, Macmillan communities in different ways, that just connects the people with, you know, connects the professionals, the cancer pathway with the people who need that kind of support, but also we can help people engage with screening, which is prevention, where there is a huge problem. Ask for help campaigns. Ethnic communities don't ask for help. Why not? Because, hey, look, you know, have you got any symptoms? Yes, I think I've got, no, I haven't got any symptoms. I've got acid reflux and some irritable bowel problems. But then my brother-in-law had the same and he was fine. So I think it's just something routine. No, because my brother ignored those symptoms. I had mild symptoms, very mild bloating, and I went to see my GP, and I'm here. I can tell you that even in my book also, I chart my twin brothers, like what not to do, what happens, how when you engage with communities, how it can improve your quality of life. Even scientifically, we know that stress and anxiety suppresses your immune system and therefore affects your response to treatment. So we want to improve the quality of life of people going on chemo, no matter how long that people have got. It's just making sure that they've got what you call help along the way to improve outcomes as best as possible. And then I'm doing some collaborative work with One Vision and the South Asian Heritage Association, which are both charity organization, and the developing community work to reach ethnically diverse groups. And again, one channel to getting through to communities, supporting faith communities in their work in promoting knowledge and awareness about cancer. And I did mention our work on mental health and neurodiversity at the beginning. There is a charity called Advance in Hertfordshire, and Amanda Ludlow, my co-investigator, and I will be taking this theme forward on mental health support, and we will be engaging a network of charities that at the moment, people with neurodiversity and mental health problems don't have a pathway to go anywhere. And a lot of the charities end up picking up this work. So these are just some examples, and I'll be very happy to discuss, more at another time, or this is just to give you an examples of the work that we do. Hey, the right-hand side is my elderly mother, who was told that I had pneumonia, that, my outlook doesn't look good. And yes, I'm here. And yes to life, because I've been through both. I've been through my twin brother's end of life care. I've been through my own. And fortunately, my professional work that I do in public health, taking it in the community, has come together with all my voluntary work, where we can make a little bit of difference. Sometimes people ask me, what difference can you make? And I said, it's a bit like, you don't have to run for 4 hours every day to make a difference to your health. You just got to walk 10 minutes every day. And it's that little bit of difference that can have a huge impact on your emotional health, your psychological health, and your physical health too. So thank you very much indeed. And there are some links here for some of the work that I've been talking about. Thank you.
Thank you very much, Daksha. There's some wonderful and interesting messages that you've put across. Now, I'm quite sure there'll be a number of questions from our audience. I see Hugh McLean's on the call. You're obviously very involved in community health, Hugh.
Yes, and it's very interesting, Gordon, that the lady's experience is very similar to what we've found. And obviously, as you know, we're in a rural area of Scotland. But people who have issues with health find what being done for them and with them in the community much more powerful than just engaging with the statutory agencies, whether that be health or social care. And message was given to me quite a number of years ago by one of our clients who said, when I'm here, I'm a client. When I go into the hospital or into any NHS, I'm a patient. Psychologically, there's a world of difference. And I remember that from about 8 years ago. So I think, sorry, I'm going to get it wrong. Daksha's experience, I think, resonates very much with me. While she's been dealing with cancer and with one particular culture group, I think the principles that which she's talking about apply across the board.
Thanks, Hugh.
Yeah, do you want, is it okay for me to comment?
Yes, absolutely, yes,
Yeah.
thanks.
No, and that's so true. And that's why I gave examples of some of the mental health work that we do in improving outcomes. You're so right. I think what I'm finding is back to the drawing board, what is community engagement? And it's really, what is it? And what we do know from work is community engagement, there is published research on effective community engagement improves relationships and trust and interaction. We will not know at the moment whether it will have an effect on outcomes, but we do know it has an impact on emotional health and psychological health. But I think when people are going through other chronic conditions, whether it's mental health or cancer, they want to talk to somebody because a lot of people are not necessarily dependent and just sit there and say, I can't do anything because nobody's told me what to do. More people are seeking, they want to be listened to, and more people are thinking, what can I do so that my journey improves with my family? I could not talk to my families. Well, I don't have much of a family left now. I'm an elderly mother. My brothers have died, but my extended family, in our culture, our extended families, our cousins and uncles and aunties are like our close family, because I didn't want people to assume the worst, because people don't know the facts and facts around cancer dying. Just because one person has got an aggressive esophageal cancer and died doesn't mean the other person has died. So people need to recognize the differences and the variations in cancer experience. And what I'm planning to do, following on from the South Asian, the breast cancer XP of the AWCG, is to maybe plan some training workshops for health professionals and bring the AWCG together with the health professionals and kind of do a workshop on how can we address these barriers and develop solutions together. Because so thank you for that, Hugh.
Peter Latham.
I think that, sorry, Gordon, I don't want to dominate.
You've got a follow-on question, Hugh.
it's not really a question. It's interesting that we have the same experience, because what community engagement means to people in the community and what it means to people in the, let's say, the NHS is completely different. And that requires engagement and a build-up of trust. It's not something that can happens immediately. But to a certain extent, the health professionals need to realise that people will want to have more time to talk, which the NH people working in the NH don't have time to talk. But, but people in the communities do have time and are happy to take the time. But I think it's very early stages, but if you actually look at where health is created, it's created in communities. It's not created in the NHS. The NHS is only there to fix us when we're broken. But whether we're healthy or not, that's in the community. So the community has a much more profound impact on helping people be healthy than has been realised before. Sorry,
yes, and
Gordon,
that's so
I'll shut up
true.
now.
No, I'm so true. The example I gave about the Gurudwara where we went, if I was told to go there and do a cancer awareness workshop, do you know what? It wouldn't have worked as successfully as a whole team of us went together. The community want to see that we are all working on the same page and that we've got the same concerns. So the primary care network, the clinicians, the health professionals, Macmillan nurses, community people. And I think you mentioned about less time. And that's really challenging. Providing cancer support, even post-COVID, has been very challenging because even less time is available. So the cancer support groups have a place, have a value, and they need to be more talked about. I think the campaigns, what the cancer support groups can't do, for example, the Asian Women's Cancer Group is a community voluntary group, and it relies on people supporting them to do some work. And I think it's like involving them, but also have some incentives for them, because people cannot be stretched. If people feel they're stretched, they won't be able to engage with the pathways that could make a difference. So, supporting that value of the, certain cancer groups are, ours is, compared to the Asian Women's Cancer Group, our cancer support group in mid Bedfordshire, which is a very rural area, is small, but it's very active, it's focused, and the primary care network of 25 to 30 GPs have already started, disseminating the leaflet we produce. So people want to be, people with cancer, and if they want to be involved. I also found out that knowledge and awareness is such an important thing, because when you're diagnosed with cancer, you could just sit back and you could be a very compliant patient where you've been told, you don't need to do anything. The multidisciplinary team will get in touch with you. That's what I was told. And it took ages before somebody came back to me. And in the meantime, what do I do? Where do I go? I was very low, because I wanted to protect my mum. So these are such cultural things. And I the stories within the communities. And you're so right that, where does the health come? We're all patients, we're all individuals, and we all have our needs. So it's not a new concept, it's just implementing it again.
Could I now invite Peter Latham to put his question?
Yes, thank you for that talk. Very informative and very impressive. The complexity, well, it is so complex, and the wide-ranging way in which you approach it. But my point is a very simple one. What you're doing is, as I said earlier, very valuable in what it offers and how it can help people. But my experience is that unless you start dealing with health issues by being very aggressive and pushy with the organisation we mostly deal with, the National Health Service, or even beyond that, the private sector, then everyone, irrespective of race, creed, belief, is isolated. And the people who are really isolated are the to say it in so many words, the people who are probably less educated, less aware of what's going on, the people who are deprived. And it seems to me that the work you're doing is moving in the right direction, but how on earth can 90% of the population benefit in any sort of realistic timescale to what you're doing? I mean, it does seem to me that unless you push, and I have experience of that, not for myself, but I do have experience of that, and unless you push very hard, it's very difficult to get any response. And the most important and first response is to get a response from the professionals. I will say that having got through to the professionals, the secondary support from voluntary organisations and many of the, let's say, advisory people, nurses, let's say, they often give a lot of help, but it's only when you've started off by being pushy and aggressive. And I think our health system is failing badly.
Yeah, and no, thank you for that. So I've got two thoughts on the being pushy and aggressive as well, but I've also got a very positive thought on what has been initiated in more recent years. So given that the type of work that I'm doing is because it's been partnership working with NHS Cancer Alliance, NHS Services, it's been recognized that there are no community navigators or community connectors. So now with the implementation of a holistic tool comes, again, it's fragmented in the UK. Not everybody's got it. Some cancer services have a cancer navigator now, which we didn't have before. And the cancer navigator apparently takes you through your entire journey from diagnosis. So I don't have any experience because I didn't have a cancer. And people in my group, I mean, in Bedfordshire, don't have experience because it's a relatively new thing. And if that takes off, we have to wait and see whether that makes a difference. And cancer navigators or cancer connectors, same thing. But this is something that is being trialed at the NHS Cancer Services. Hence, not everybody's got a cancer navigator. Hence, not everybody's got a holistic. So the cancer navigator is the person who does your holistic, like what else do you need, your emotional, your quality of life, how you're doing with your cancer journey. Whereas your clinical nurse specialist is really there to do your follow-ups and just kind of you go for your scans and things like that. So we will yet to see, Peter, whether that model is going to be working, where it's going to be working, whether the outcomes are really changing. And my second thought on your pushiness is, in reality, Peter, even in the group where I am in Bedfordshire, very rural middle-class area, the people who come to the group, they are afraid to say anything because they feel that their care will be affected. You know? So somebody needs to listen, and that's why I'm putting my bets on cancer navigators and cancer connectors, because if they are appointed by the NHS or Macmillan or together, and they are going to take each family through their journey, you know, they will be able to pick up what the patient needs. And again, the value of a cancer support group is not actually, you know, you sit back and everybody somebody will call you, somebody will do this. No, you need to enable them, to signpost them, to convince them to say, look, 3 people would say in my group, I've been through this and I took a list of things to my consultant. Nobody called me for a scan. And I went with a list of things. I sent an informal email, not a complaint, but to say, I'm really lost and I'm fearful. I've been told that my cancer doesn't look good, but nobody's talked to me. And it's just that empower people to know that their cancer care will not be affected if they are moving forward and asking questions, which I'm not going to call pushy or aggressive, because I think this is the fear that cancer patients and their family have, that if they're going to be pushy and aggressive. But what does help, which is what I can say also another initiative, because I spoke at that, there is a formal health inequalities training module for all clinicians and nurses, which is being rolled out in primary care. And I went to that, and in their training, they are getting live examples of where the gaps in their provision to meet the needs are. Things like, what can they do so patients feel that if they're going to be pushy or they speak up, the care might be affected. So again, it was last year that I went to this health inequalities training that was offered to clinicians who look after care. So the outcomes from those are yet to be seen. So they're relatively new initiatives. But there is a big concern, Peter, even in the groups that we have, that I was afraid to take anybody with me because I didn't want people to think that, who's going to look after me. And then I didn't have the questions, and I was afraid to ask the questions because the clinician was very busy, kind of looked at his watch and said, okay, then you can go for your first chemo next time, and then with your follow-up, we'll discuss with you. You're right. You need that bridge. You need those navigators and connectors. I mean, it was 3 days before New Year, and I came out of the hospital, and I was like, everything's to see. What do I do now? I'm living with untreated cancer, which is aggressive, of which my twin brother died. I was told it didn't look very good because he was aggressive. And that was it, really. And when when the Macmillan nurse took me to another room, she actually said, bless her, that she's not an esophageal nurse, she's a colorectal nurse, so she can't really help me, but she's sort of there. So it was a timing just before Christmas, just before New Year, somebody had to be brought in. So all those circumstances, and I think that's why we need a voice, like a listening voice that is coming from the community, from patients. I mean, if I'd known then what I know now, I've overcome my barriers. My mom's still with me. She obviously, cried a bucket when she looked at my draft manuscript. It was the first time she heard. She's an intelligent lady, speaks English, reads English and everything. And she's not stupid. So she did think that nobody has a 9-hour surgery for nothing, something seriously wrong. But we couldn't use the word cancer because it means death and short life because of twin brothers. So yeah, so thank you.
Okay. Colin,
Could I just very quickly say that what you're talking about are problems mainly within a discipline like cancer or mental health, where the patient has a whole series of conditions and some holistic approach is necessary. My experience is that it is utterly absent, and I by default turn out to be a medical coordinator with no knowledge or experience of medicine other than what I meet day by day.
we need more of you, Peter, I think. You, Colin George.
Yeah, as a club, I think we've shared the thought that was expressed earlier that the NHS is about picking up the pieces, and we've concentrated really on prevention. And the area that we've concentrated on really is in the schools, particularly the primary schools, and trying to deal with the whole dimensions of how you give children the confidence, the knowledge, the skills, the attitudes to think about and organize their own health, and also think about what they do if they have a problem. And a particular charity that we've supported for many years is Quorum Life Education, and that is trying to prepare children for their responsibility for their own welfare, thinking about their own mental health, thinking about their own health, and in a sense, the preventative side of everything that you've been talking about for the next generation seems as important as all the work that you're doing, which hopefully will have a much quicker payoff.
Absolutely. So we are looking at, in my work, is the whole cancer journey was around prevention, diagnosis, and treatment. And therefore, all the screening programs are prevention and attendance at screening program. Again, there's a huge, the screening uptake in some diverse communities is lower than the indigenous. Yeah. And so when we're doing our work, we're addressing the whole journey, which is prevention. Because for a family, say in one of my groups at the AWCG, a family member might have had cancer, which came out of blue. she was probably under 50, so she was not accessible to screening programs, even with the bowel cancer, unless you are 58 and over, you wouldn't have a bowel screening. So she knew that, you know, her family members had cancer, but they didn't have the opportunity for any kind of screening or prevention. So she is more engaging now with prevention, going back, looking for symptoms, sharing it with the community. And I think it's like also demystifying some of the things like, you know, or you could have a family to say, my sister's screening was negative, so I'll be okay. People don't understand that, you know, genetics is not as simple as mathematical as that. So you're so right. If you can get the uptake of screening programs addressed in many communities, then the experience that will follow will be more kind of transformative, more engaging by them, and maybe they might be also be more proactive in developing
it's trying to give them
solutions.
the it's trying to give people, young
confidence,
children,
yes.
the confidence to actually approach either other people or the health service or whoever, but giving them the confidence to actually both recognize when there's an issue that they have, and the skills, attitudes, and so on to actually feel that they got a right and there's an expectation that they will come forward.
And that's early
that
years.
slots neatly into your preventative.
Yes, absolutely. And what I like about
tests,
what I like about that is the early years. You know, the earlier you catch them, the more, you know, they've got a way of thinking, a way of going forward. A lot of the work that we're doing in the community is for screening uptake. It's usually for cancer screening, and normally for cancer screening it's over 50. So people are set in their cultures, in their thoughts, in their notions, in their beliefs. And even today, after all this work, we have a couple of people who say, I still haven't got the fear of not speaking up when I see my consultant. You know.
Okay, any other questions? I think, Daksha, we have been making progress. It's not that long ago the two words breast cancer wouldn't be mentioned in the public newspapers or radios and things. So we're now talking about it. Some people understand that early diagnosis is the key to getting over cancer. And I'm quite sure you diagnosed yourself quicker than your brothers diagnosed themselves, I'm guessing.
Well, it's interesting you say that. Yeah, my brother had some symptoms like bloating and acid reflux, and I must admit he was told that he's had inflammation, so they tried to treat it with antibiotics for a couple of months, and then it didn't work, and then he got this horrendous terminally ill diagnosis. Mine was really out of the blue. I went for a routine. I went to see my GP because I'm a diabetic, or was a diabetic, and she just wanted to check my HbA1c and my medication, and then she just said, you know, everything else okay? And I said, well, yeah. I said, nothing to worry about. I said, just got a slight bloating and, you know, just a little bit of discomfort. I said, just irritable bowels. I'm sure it's nothing. And she said, yeah, well, I'll tell you what we'll do. I'll send you for an endoscopy and I'll send you for a colonoscopy as well at the same time. And we're not expecting to find anything. And hey, she acted. You know, and when I asked her afterwards, and of course I've acknowledged her in my book, and I asked Dr. Collins afterwards, I said, what was it? I can't be a light bulb moment. And she said, do you know what, Daksha, at the back of my mind was your twin brother.
Mm-hmm.
And she said, the learning from there is when you go and see your GP and you're giving them your clinical history, always tell them about your family history. Because you will find one GP who will look at the notes and said, it's had a family history. I wonder whether I should do something. And she acted on that. And if she hadn't, I wouldn't be here trying to make a small difference to people's life and give positive experiences. And so it was really unusual that way. But I went for a routine test. But if I had had symptoms, yes, if I had major symptoms like my twin brother did, yes, you're right, Gordon, I would have learning from what twin brother could not do or did not do, I would have gone forward and said, I've got this. But whether I would have got an endoscopy or not, because there is this other thing, if you go with symptoms of acid reflux or bloating, they will give you some anti-reflux medication for 3 months to see if it goes away. But in my case, Helen Collins knew about my twin brother because I was very vocal about it. And when they take any, have you got family history of diabetes? Oh, yes, I said, being Asian means heart disease and diabetes. I have got a family history of diabetes. But actually, I said, my twin brother's on end-of-life care from cancer. So she remembered that and she put that in her notes. So it's that dialogue, it's that communication. And I think if every patient was encouraged to give that family history, sometimes people come over and say, oh, I didn't think of that. I didn't think it's important. Nobody's going to get cancer. So, it's that educational about, communication and how you're communicating. And it's a two-way thing.
Your talk, Daksha, was very powerful, very informative, and it's been recorded. So we'll send you the link to this talk, and then you can spread it around all the groups and people of interest, and then they can pass that around as well. I think people just need to be told to be more confident and go and ask more questions, I think.
Yes.
So we'll do that.
Thank you.
Any other questions before we close up for this evening? Okay, well, thank you very much, Daksha. That was fascinating.
Well, thank you.
Thank you
Thank
very
you for
much.
inviting me. It's been really delightful and it's been really great sharing this platform with you. So thank you very much.
Okay, thanks very much. Good night. Oh, can I just,
Bye-bye.
before you go, can
Oh.
I was going to say something else. We've
Sure.
got another talk coming up in November, which I can't just get the details. So in November, we've got Fiona Clark, who delivered a talk some 3 years ago on racism without racists, which was very impactful, like the talk this evening, and reached almost 400 viewers over the time.
Oh, wow.
So so she's coming to talk to us again in November. So can I just invite you all to raise your glass and toast the King, Rotary, and the people of Israel and Gaza who are suffering so much.
Rotary
Yeah.
in the Gaza.
Well, thank you and good night.
Will there be a link for Fiona's talk on your website?
Yes, we'll send that to you, Daksha, as well.
Thank you. Thank you very much indeed. Thank you.
Thank you.
Bye. Bye.
Thank you. Good
Good night.
night. Good night.